Hi, everybody. I'm Julie DeLiberti. I'm a professor of humanities at the College of DuPage, and I'm with Dr. Kathleen Finan, who is a professor of biology at College of DuPage, and with Professor Gallyot, who is our interim dean of health sciences and nursing, who's a registered nurse and a critical care nurse as well. Is that correct, Dilyss? Am I making stuff up here? She also has an MBA in business, and so we have some medical professionals here. You remember them from our first chat, where we talked about. I made them wear masks today because we don't want to infect anyone, and they obliged me. So okay. We are here to talk about all kinds of things like wearing masks, treatments, testing, whether antibodies are good or bad, whether you can get reinfected, and also we want to talk about what school will look like when we go back in the fall. What those of you who will be returning to campus, most of us won't, but if you end up returning to campus for some reason, what that might look like. Are we ready to launch, ladies?
I think so. Julia, I want to compliment you on the fact that you are wearing your mask correctly, that your mask is covering both your nose and your mouth, and that you're not pulling it down in order to be more comfortable. I think
this is inappropriate.
That is inappropriate.
This is not even on.
Dr. Gallyot, having it on your chin is not real effective. So Julia is wearing it correctly. Happy to say.
Absolutely. Although, Julia, are you within 6 feet of another person?
I am not.
Okay. So what I can say is because you're in your home and you're not around another person, so that we can do this and people can see our facial expressions without infecting other people.
Are you guys not 6 feet?
I don't have anybody else within 6 feet around me, and I'm in my home. I'm taking off my mask because that's appropriate to do.
All right, dude, I think we're good.
I'm going to take mine off as well. I'm in my office at home, and I have nobody else in the office with me. So it's safe to do this. I won't be exposing anybody else.
Okay, so if I'm out walking on the street and nobody's around, I don't need the mask. 6 feet around.
I think that's correct, Julia.
Okay.
I think
all right.
If it's possible to stay 6 feet away from everyone else when you're outside, I think that is okay not to wear your mask, although there's no harm in wearing it.
Okay. I get together with some friends, say, for example, a family gathering. I trust everybody. I know they're isolating. That's what they tell me. I don't need a mask, right?
The mask is there to protect other people from you, not to protect you from them.
What? What do you mean?
When you have your nose and mouth covered, you tend to decrease the spray and the particles that can come from you. So by wearing a mask, you decrease that, and by being 6 feet away, that adds much more distance from other people potentially getting whatever it is that you have. Because remember, you can be asymptomatic and still spread coronavirus.
Okay.
And I think it's not a matter of trusting people. It's a matter of recognizing that we're all in this together, and we all need to do what we can to reduce the spread.
So basically you're saying it's the same thing. Oh my God, where'd Kathy and Dilyss go? Like, I'm legally blind without these glasses, and I wear them to drive. I could drive fine without them. I'm just protecting other people. I mean, it doesn't matter that I can't see. I'll be fine, right? But I'm putting these on because I'm trying to protect it. It's the same thing is what you're saying, is me wearing glasses and the mask.
It's similar.
Okay. Okay, well, so that's masking. Let's talk about some others. Thank you for the edge. I feel safe in my house now. I thought I could just reinfect myself. Just kidding. Thank you. And so we're going to talk about some testing and some treatment and some other things about COVID. I want to start out by showing you two things, and Kathy and Dilyss have agreed to indulge me in sharing my screen here. The first thing I want to show you is this cartoon that comes from Cartooning for Peace. And Kathy and Dilyss, do you have any thoughts about it? Do you think it's an appropriate cartoon as we talk about COVID and the ensuing issues?
I think that's where we're at right now. There's a puzzle. It's a puzzle as to how we crack some of this. And And many people are trying to decode the treatment for it, although we're still far from some of that.
Yeah, we're decoding the disease as well, too, so we don't even know where to hit, right?
I think we also have to remember that the most important thing that we can do is not just wait and hope for a treatment or a vaccine, but our main job is prevention, and that's not part of this graphic.
Okay, so this is about the scientists trying to explore, or this is about the people, okay, well, our prevention. Well, and speaking of prevention, I'm going to take us to the jury statistics, and then you guys are going to bring us back home locally, and I'm going to let you have your run with it. Forgot to hit share screen. I'll be right back with you all here. I'm sorry. I like to refer to the Johns Hopkins live map. It gives statistics about the world, and it gives statistics, here's global deaths, and it gives statistics about the US itself, and then you can look at other countries by region, and then you can just see the live map. This is updated daily. So the global deaths have been 715,000, and the United States, we have, shoot, I looked up the number, but it's about 150,000, am I correct? And then, in June of 2020, that we were approaching 10 million deaths. It's just past July, and we've almost doubled. I'm sorry, global cases. I'm sorry. We were approaching 10 million global cases, and now we've almost doubled in just over a month. So these are some sobering statistics, and I know if we look around the world, North America is completely covered. South America has some spots. I think this is what, Argentina-ish. People are thinking that Africa should be as covered as North America is, but we know that Africa had some pretty strict lockdowns from the beginning, and they had an Ebola scare a long time ago, and so they have some really strict protocols in place for when pandemics happen, which I think explains why there's a lot of not red in Africa. Do you guys have any things you want to talk about here? I just want to give us a global sense of our pandemic and prevention and masking.
I think in Latin America and in India, one big problem is the density of population, because we know that the closer together people are on a daily basis, the more chance there is of spreading. I think the gaps that we're looking at in Latin America may be due to the fact that some areas of South America have a less dense population, and some countries are doing better than others at reducing spread.
Okay.
And as people get, this is a global pandemic. This is not blamed on one specific region. And as people travel, it spreads, and it spreads quite quickly. So as you see areas that are less dense, that Professor Finan was talking about, absolutely, there's not as much travel there. If you even look at the state of Illinois, areas that were less populated don't have as many outbreaks because there's less people there. Where you have more people, there's a bigger chance of actually seeing it. Yes, masks.
So I guess I just wanted to sort of, okay, thank you. And I apologize. So I was in my discussion, I was confusing number of cases with number of deaths. They're not at all the same thing, because if you're diagnosed or get COVID, you're not going to die from it necessarily. You may, right?
No, we've been running, in the state of Illinois, we've been running anywhere from 3 to 5% as far as our mortality rate from COVID cases.
So let me just turn it over to you guys and ask you to sort of take on these questions of treatment and testing and what fall will look like, and things that you think are relevant for folks to know about what's going on with COVID. 3 months later, the first time we talked about this was May 2nd. And so it's a little over 3 months since we last met, and things have changed dramatically since then. So take it away. I'm just going to turn it over to the medical people.
Dr. Gallyot, did you want to start?
I want to start. Well, in some ways, things haven't really changed a whole lot, have they? We've got a lot more cases, but we still are looking at how do we treat this? What are the symptoms? We're honing down on some of the symptoms, but again, we've got asymptomatic people. So what I'm going to say is, in 3 months, even though it seems like a long time ago, things remain the same. As I look at the state of Illinois and say there's been a lot of good things that have happened. Whenever you lock things down to prevent a pandemic, there are other things that happen. Our economy, for one, is an issue. And I'm not saying that you open things up and roll the dice on the pandemic. I'm just saying by closing things down, there are other consequences to managing this pandemic. Dr. Finan, do you want to talk about some of the treatments and testing?
I think we need to keep in mind that testing and contact tracing is really going to be the key to controlling the spread further. What we've been seeing over the past 3 months is not just the fact that people are getting tired of wearing masks and being distant. It's also that the testing capacities in the United States, some areas more than others, are just not yet up to the numbers that are needed. And another thing is that what is valuable about testing is the ability to get back results rapidly. Mm-hmm. And there's too many places where testing and the availability of results is still far too long of a wait. People are still waiting to get tests. Not necessarily in Chicago. Testing seems to be fairly available. But the wait for testing results, if we're not getting testing results back in a day or 2 days, it doesn't matter. The testing is wasted. Because what we need to do to trace contacts is to have data about who is infected. Tracing their contacts, by the time you wait a week, if they are positive, they've already exposed perhaps dozens of other people, and contact tracing is not going to contain the spread from that one infected person.
I know some people are worried that contact tracing is a means to social control or for the government to spy on us. And I just want to point out that contact tracing actually has been happening since AIDS, right? In the 80s, when they wanted to know who you'd had contact with. It actually happens when they ask you, when they talk to you about STDs and if you've had them and who they should notify if you have one. So that's not Absolutely. A confession. I haven't said, but I mean, I'm just saying that people think that contact tracing is new. And so I just want to tell people it's an old practice, but just the sheer numbers, it's more needed now. So contact tracing means I am sick, I come to you and you say who all of you talked to, or do I have to talk to somebody else? Dilyss, you were going to say something. I'm sorry.
I was in the 80s. They discovered who patient 0 was through contact tracing practices. And because patient 0 in the AIDS epidemic kept a journal, they were able to look at how how AIDS was spread through North America because of where this person traveled. It is not a way to control people. It is a way to try to control the spread of disease. And as Dr. Finan was saying, for some of the tests that I've heard of that people have been waiting, the results can take up to 10 days. Well, the quarantine is 14 days. So in some cases, there's rapid results, but I don't know how accurate some of those things are. We need accuracy and speed for both things. So
is there increased accuracy in the testing since 3 months ago?
I don't know that it has increased in accuracy. I think the tests themselves, although they don't give positive results in every case, I think the positive results overall have been pretty reliable. A negative test does not mean that you absolutely don't have the infection or have not been exposed. I think the sensitivity of the test to detect positive cases is adequate, and I don't know that it is the main issue at this point.
So testing needs to, are we not doing enough testing because there's not enough personnel to do it? Because we're not, I mean, do you have any thoughts on that? Is it just that we don't have enough tests still? And I guess more positively, should we all be going to get tested if there, I know there's some places in DuPage County where we can get tested. Should we all be going to get tested for preventative, or should we wait until we have symptoms?
I think it's important that people who know that they've been exposed to somebody who has a confirmed positive test result, that they consider being tested even without symptoms. We know, especially in younger people, as Dr. Gallyot has said a couple of times today, the importance of asymptomatic spread from one person to another without having any symptoms. We know that that does occur. That's one thing that we have learned in the past 3 months, is how important that method of spread is. And so people who do have had significant exposure, not just passing in a brief conversation appropriately distanced, we're talking about significant exposure. Even without symptoms, they should get a test. Anyone who does have symptoms absolutely should get a test.
Okay.
But the value of testing everybody without exposure and without symptoms, the reliability of the test does go down at that point, and the capacity is also a significant issue. So overwhelming the system with tests that are not going to provide useful information is still a problem. We still do need to increase our testing capacity.
Dilyss, your face is communicating much. Go on.
It is here. I love you, Kath. I do not have the title of doctor. I'm working on it, but I don't have that, so I don't want to mislead people. I'm working on it. All but dissertation is where we're at right now. So thank you for that energizing boost, but I don't want to mislead anybody. I'm a nurse. I'm an advanced practice nurse with some other titles. So understand that I'm really not trying to mislead anybody. I do believe that when it comes to testing, if you have been exposed, there's a certain period of time, we're saying between 3 to 5 days, because if you get exposed today, if you get tested tomorrow, you may have a negative test. From what I've seen in some of the literature, waiting about 3 days until you get tested. But again, we're waiting for how fast does that test turn around, because I've had people who've had their spouse has been exposed, their spouse has been tested, so they're saying, well, should I be tested? We don't have the results of your spouse's results back yet, and perhaps you need to wait 3 to 5 days before you get tested too. That's where that whole contact tracing starts to come in to play. How many people? One person can infect as many as 100 very innocently.
So do get tested if you have symptoms or if you've been exposed. Don't get tested if you have no symptoms and you've been sort of vigilant about keeping your distance and wearing your mask. And okay, okay.
I would agree.
Okay, so then so that's about testing and some thoughts on testing. And then before we started this conversation, you guys were talking about whether or not people can get reinfected. And 3 months ago, there was still debate, can we or can't we? And some people were saying you can't, and then China was saying we've been having some results that say you can. So are we any further on that discussion? Can you get reinfected?
But what I have seen is that people who wind up with coronavirus, who get hospitalized, what I've heard from is they get hospitalized. And a few months ago, I had not heard of a potential reinfection of coronavirus, but it appears that some folks, 8 weeks after recovering, I'm going to put recovering in quotes, recovering from coronavirus, wind up getting symptomatic again. There were people who were walking around saying, I've got antibodies, don't worry, I can't spread it to you. And I think that we need to continue to wear masks, whether you've had coronavirus or not. But we were having a really good conversation, and Dr. Finan had some an interesting viewpoint about your immune system. And perhaps maybe this is not a reinfection, but perhaps this is the way that your immune system is managing what's happened with coronavirus. You want to talk more about that?
Sure. There's still a great deal to be learned about how this virus affects our immune system, let's say, how our immune system reacts to the virus. A lot of the symptoms that people get, just like with other infectious diseases, the symptoms that people show after infection are not just directly due to damage to organs from the virus. They are in part due to our immune system's reaction to the virus. So I think it may be the case that there will be some examples, a number of examples of reinfection. Certainly I don't disagree that that's possible. I think maybe they get more attention than is warranted, because it may actually be that those who've had a positive test, who've been symptomatic, and who have recovered, it may be that the reemergence of symptoms 8 weeks later, perhaps longer, might be due to the way that our immune system handles this virus, and that it's not the virus reinfecting, it's a reactivation of our immune system for some reason that we don't understand at all. So I think there are too many questions out to know for sure whether reinfection is a significant problem. I think potentially it could be. I just don't know that we're going to see, or we have been seeing the numbers of cases to believe that it's a common problem.
But as of this recording, were you going to say something, Dilyss? I'm sorry.
No.
No,
I'm trying not to touch my face, but
but you will wash your hands. Don't lick them.
Yes.
Just don't lick them. You, as of this recording, Kathy and Dilyss, as far as you know, there are no approved treatments for COVID in the United States.
that's correct.
Yeah.
I think that people are working on them. Remdesivir was something that was brought out earlier, and I think that in some of the earlier trials, they have decreased the length of hospital stays, but it's not something that you would take prophylactically, not to get coronavirus. Is that what your understanding is, Professor Finan?
Yes. The drug treatments that have been discussed, I think mostly that's in the context of people who have had severe symptoms and who've been hospitalized. There's some encouraging data on the use of some other drugs that we are very familiar with, such as dexamethasone, but it's all been in the context of treating those who are most severely affected and who are critically ill, reducing the length of time and the necessity for artificial ventilation. But as far as any treatments that are available for the people who have less severe cases, or people who want to prevent infection, we have no treatments or preventatives of any kind at this point.
So we are hearing a lot less about ventilators and the need for them. I'm wondering if that's partly because of these treatments. I know they were, and I don't have an answer to that, but I know too, as you guys were talking about, they did think that they might have had a breakthrough with some HIV drugs and with some Ebola drugs, and I know that and some blood pressure medications, but I know that all those have sort of stalled or have not been peer reviewed or have not been. So yeah, I know there's lots of people out there working. Let me make it more local and direct. If you talk to Dilyss and Kathy, I was sort of bragging that I had learned a song on the ukulele this summer, but they have been doing these fantastic initiatives, like setting up protocols for how to get students into COD who might have to return to COD, and Kathy for teaching video online for some courses. So can you tell us, let's move from this big global to daily life. When we go back in the fall, our life is going to be changed drastically. I am in a discipline that will be teaching fully online. Kathy, you might have been, but now you guys can be fully online with some audiovisual help. And then Professor Gallyot, you've got some stuff going on. You actually have to have people on campus. So can you tell us what education and returning to campus will look like, and what we have to do, and can we use a bathroom, and can we, touch a drinking fountain, and all these things? So
Sure. I'd be happy to help you with that. Well, first of all, we need to really communicate with people that no one can come to campus without a mask. To even walk into the buildings, they need to be wearing a mask. When they come in, there are several entrances that will be open. There will be screeners there. Screeners will ask them questions such as, have you had a temperature within the last 72 hours? That's one of the protocols that we're using. Are you short of breath? Do you have a cough? Have you been around anybody with COVID-19, you or your family members, within the last 10 days? If any of those answers are yes, we won't admit that student. We'll take their name and let the appropriate people know. Also, in my disciplines, that's nursing and health sciences, we have a lot of people who work in healthcare. And in some of our protocols, we've written, if you work on a COVID unit, you work with COVID patients, you can't come to the campus. Even though they don't have COVID, the chances of you getting COVID, because we do have healthcare workers who are coming down with COVID, who are wearing the appropriate PPE. If you're spending 12 hours a day with COVID patients, we have seen some healthcare workers coming down with that. So to ensure that we're trying to keep the campus safe for everybody, because safety is our guiding principle, we're asking that those students don't come to campus, and then we're going to have to work with them to see what we can do. None of my faculty are working with COVID patients, so they'll be able to do teaching. If we've got faculty, if we've got adjunct or even full-time faculty who work on a COVID unit, I can't have them come to school. Of course they can teach online, but I can't have them in close proximity with the students.
So there can be some contact in some classes, because in nursing and other fields, there's state requirements and licensures that are at stake. But I want to go back to one thing you said. There will be some doors open, so not everywhere on campus is going to be open.
No. The reason being is we kind of have to stream patients into the school. And if you have too many doors open, you can be sort of anywhere. So there'll only be specified doors that are open at the college. People will be screened. They'll be asked their names, and those reports will kind of go out. I will say, though, that we have had people who made up their spring and summer courses this summer in the Health and Science building. And so we've been screening people, not quite on the level that we're going to in fall, but we've been screening people since June 15th. And we've had between 50 and 150 people a day that we've been screening safely on campus. But we also want to limit the amount of time that people are on campus. So it's not that we don't want you to stay, but we'd prefer you to take your class and go home, or go have lunch someplace. If you have more than one class, come on back, because there's not what you mentioned, water fountains. Our water fountains have been kind of taped off so that because you cannot step 6 feet away from them. So those things are taped off. Our students need to bring lunch and whatever they need to drink. But again, kind of hard to do that with a mask on. So
can I use a bathroom there?
Absolutely. There's nothing wrong with using a bathroom. There's stalls that will keep you apart. Make sure that you wash your hands. It's still the same routine. You have to wash your hands. Continue to wear a mask when you're in a stall, though. If some people are having a hard time wearing a mask, they need to ask for a break to be able to go outside the building so they can take off the mask, put the mask back on, and come back in.
So it's not touching doors or toilets per se. It's the fact that you might lick your fingers or stick them in your eye after you've done so, right? I mean, that's why we wash our hands. It's not that we can't touch stuff. It's that we just need to be vigilant about making sure that we don't make contact with our face. Okay.
A lot of the extra hand sanitizers have been, I don't know how many more, I think they came up with 60 more hand sanitizing stations.
Great.
And so that's a wonderful thing, but people just need to remember to wash their hands. When I was working with screeners this summer, as people would come up to the desk, they'd say, wash your hands. But you're a little vigilant, okay, but they'd say, wash your hands, because you just wanted people to remember
Sure.
that's important. And try not to touch your face. Try not to touch
or anyone
your face.
else's, right? Or anyone else's.
Correct.
Kathy, what you want to tell us? Oh, go ahead. Yeah.
No, I think one thing that students also need to expect is that they will have their temperatures taken as soon as they walk in the building. And anyone who does have a temperature above 100.4 degrees Fahrenheit will not be able to remain in the building regardless of whether they've regardless of whether they're wearing a mask, regardless of whether they've had symptoms or had contact with anyone. And
104
it is
is high, right?
100.4.
Oh my God, I was like, what? Thank you. I'm 100.4 because I'm like 104. You should be in the hospital anyway. Okay. Okay, good. All right. Thank you.
And I think it is incumbent on students to take the responsibility if they are feeling ill, if they do have elevated temperature, not to come to campus, to communicate with their professor, to let them know that they will not be able to come to campus that day if it is otherwise expected that they would be there.
So they can try the next day, or they can
They
can come back the next day. Okay.
Again, they should self-monitor if they're not having symptoms and they do not have an elevated temperature at home.
And sort of be honest about where they've been. Have they been to places where they could have been exposed?
Correct.
Well,
and we don't know where those places are because we don't know if you innocently go shopping and you don't know that the person in front of you, perhaps, or there's a whole new way of living now. Yes, just putting your mask back on. There's a whole new way of living now, and so. Kathy, thank you so much for mentioning the thermometer. I just completely ditzed out as I was dropping into the protocol, but everybody's temperature will be checked. And if you're not feeling well, do not come to school. I have seen so many of my students, not even COVID related, thank you, who are sick. They will drag themselves to school. We're no longer suggesting that that's appropriate. Stay home if you're not well. If somebody else at home has COVID, please don't bring that to campus. Thank you.
And Professor Finan, Dr. Finan, you were sort of talking about some things that you're doing so that, because you are teaching fully remotely this semester, right, this fall?
That's right.
And so you talked about some things that you're doing. And so what might that look like for students who are, so we know what it's going to look like in the humanities or philosophy, we can, but I mean, people have to look at bodies in your class, or they have to be able to do some anatomy stuff. So can you tell us how you guys have made an adjustment for students who can't come to campus?
I think the overall college guidance is that any classes that can be taught online should be. A lot of faculty have been going through training over the summer to learn innovative ways to best conduct their classes and to give students an equivalent educational experience. The anatomy and physiology faculty in particular, understanding how important it is for students to have the experience of interacting with the models. We know that they can't do that at this point. So what we've done is produced or begun a project of producing a video series where I or another professor, Dr. Tara Leswich, have demonstrated the models and narrated our way through them so that students have more than just a two-dimensional picture to try to translate into the three-dimensionality of real anatomy. My understanding.
I want to watch those, even though I'm not taking your class.
You'll be welcome to do that. They will be available to students on the library website, although we don't have that established yet. So it's still in progress. It's a work in progress. My understanding is that some cadaver lab sections of anatomy and physiology will still be held, where the lab portion will be in person. However, the sections will be smaller. I believe they'll be limited to 12 students per section plus the instructor. And again, masks are required. Distancing is going to be done as best as possible. Distancing in the bench part of the lab as much as possible. So even with that in-person experience, there will be strict protocols in place for people who are actually gathering in a room.
Okay. And I do want to say that the humanities and arts faculty and all people who are trying to do their courses all online, a lot of us have taught online for years, but we are trying to recreate. You will still have a good learning experience with our online courses too. And so I just want to add to the fact that it's not just the sciences who've been, I don't think either of you was saying that, but I do want to say that, you know, I'm on this pandemic pedagogy group, and people are just generating ideas and articles and thoughts. And so, I mean, people really are invested in, we would rather see you guys on campus, students on campus and community members, but in the interim, we will just do what we can to, yeah.
I wanted to say, I think that the idea of being online and working online, this is not previously what people have experienced. As far as, okay, let's see, what we did in spring was try to help people through this crisis, and we were reacting. We've had more time to design better courses and think about how we're interacting with our students and what's happening next. And so I think that a lot of people have gotten more education about how to do an online course and what that means. And I think that in a thoughtful way, we're going to move forward. Yeah, because we're not quite sure when this might end, truly.
Yes, I understand we are planning spring semester to be online, that we're preparing that way. And then if something miraculously happens, we will be able to come to campus. But it's easier to go from online to on campus than from on campus to online. So it's a great. Let me just say, if I weren't here and we were just recording Kathy and Dilyss talking to each other, you know, what did we not cover that you would just really want to say, or what kind of thing? Whether, you know, do you want people to know about COVID and treatment and testing in campus, or whatever you want to add before we sign off?
I think, like Dr. Gallyot was saying, we're going to be dealing with this. Professor Gallyot, sorry. I have great respect for Professor Gallyot, but what we need to consider is that a miracle is not going to happen. This is not going to disappear, and we're really in this for the long haul as far as working with online class experiences. We are all waiting and hoping anxiously for the development of an effective vaccine. But developing a vaccine and producing and distributing a vaccine are two very different things. So to hope that a vaccine will instantly become available as soon as it's developed and proven to be effective, we can't think that way. We have to we have to continue with the knowledge that prevention is really everything here. Stopping the spread, slowing the spread, prevention in terms of what we can do with distancing and masks. It's actually been very encouraging to me how well that does work when everybody adheres to the guidelines. Vaccines will come, but they are not going to be instantly available to everyone. And when they do come, they will be rolled out in terms of how the production is limited and who is the most vulnerable and really should be first in line. So I think most of us should not expect to be first in line. Most of us should continue for the foreseeable future, expecting that it's really our responsibility to protect one another, and not wait for a miracle, not say a vaccine is coming in December and things will be fine by January, because that's not how it's going to work.
Okay, so
I wanted to add to that, if that would be okay with you,
yeah,
Professor Diliberti.
and I just wanted to
That's
say,
okay.
I just wanted to remind everybody about it's not a winter, it's an ice age, and we're not even through the beginning of the ice age.
No, and what people originally thought about with this virus is it would be cyclical. In other words, there would be dips, there would be peaks and valleys. We haven't seen so many valleys, and it's not necessarily, as things slow down, for me, what I understand and what I've seen is a lot of fatigue. We're preparing for an ice age, and what people were ready for is a season. So I see people just getting very tired of wearing masks, washing their hands, and social distancing. We are social animals. We are social beings. And I enjoy spending my time with you. But in order to keep everybody safe, and safety has to be our goal, we need to keep adhering to wear your mask, wash your hands, don't touch your face, stay 6 feet away from other people. If we do that, we're actually protecting other people as well as ourselves. And I just see people fatiguing from that, like, oh, I'm so tired. But that's the way we actually keep people safe. And if I use that as a guideline, we should all be okay. We've been trying to do that. And there, as Dr. Finan had said, we're waiting for sort of a magic bullet for this vaccine. But until then, and we don't know when then will be, we're going to have to get ready for a much, much longer period of time. And I know that I'm missing my colleagues, I'm missing my students, I miss a lot of that. But I wish everybody to be safe.
Well, thank you both very much. I appreciate the time and the updates. And we'll probably have to have you back again in 3 months, because things change, things are the same, but it's good to revisit the topic. So thank you both very, very much.
Thanks.
Bye.
It's been a pleasure.